So here's the same diagram from the previous slide. During menstruation, we can observe estrogen levels beginning to rise, that you can see right here. And simultaneously, the number of GnRH receptors on the anterior pituitary begins to increase. As we just discussed, the rise in estrogen stimulates a spike in what hormone? That's right, an LH. You can see it going up here. This is going to trigger the rupture of the dominant or pre-ovulatory follicle. So one benign condition that can occur at this point in time is referred to as Mittelschmerz, which is German for middle pain. Do you know when this occurs? Mittelschmerz can occur when the blood release from the ruptured follicle irritates the peritoneum. And what other disease does this pattern of pain mimic? It causes pain resembling appendicitis. The discomfort can also cause follicular swelling, ovarian wall rupture, and fallopian tube contraction. As you can tell, this whole process is extremely regulated and sensitive, meaning a lot of things can go wrong with it. But I'll leave the suspense for now until the next session in pathology. So, let's talk about reproductive physiology during pregnancy. This all starts with fertilization. This most commonly occurs in the upper end of the fallopian tube, which is known as the ampulla. Now, this generally must occur within 1 day of ovulation, or the egg will no longer be receptive to the sperm. Implantation occurs around 6 days after fertilization, and this is when beta-HCG secretion begins. After implantation, this hormone can first be detected in the blood around 1 week after conception. Now, what bodily fluid is HCG usually found in that allows for it to be a popular over-the-counter test? Well, after another week from this point, beta-HCG will be found in the urine, which is why most home pregnancy urine tests will only detect a pregnancy when? That's right, about 2 weeks after conception. So by the time you see those 2 lines on a home pregnancy test, keep in mind that a woman's actually been pregnant for at least half a month at that point. Now, during pregnancy, progesterone and estrogen stimulate breast development and increase prolactin synthesis. However, it doesn't make sense for the mom to make milk during pregnancy, so progesterone and estrogen actually inhibit the effects of prolactin at the breast. Quick endocrine review. What regulates prolactin release from the anterior pituitary? That's right, it's dopamine. Alright, so here's a flash quiz. In which meiotic phase is an oocyte arrested until it is hormonally stimulated for ovulation? The answer is prophase of meiosis 1. Alright, so lactation. After birth, as progesterone decreases, there is relieving inhibition of prolactin secretion and leading to lactation. Additionally, suckling from the neonate actually stimulates oxytocin release and milk letdown. Do know that breast milk is the best nutrition for infants. It contains immunoglobulins, mainly IgA. This confers passive immunity for about 6 months after birth. Now, the fetus also receives passive immunity via antibodies through the placenta. Do you remember what immunoglobulin can actually cross the placenta? That's right, it's IgG. These are the reasons why many diseases you may have encountered in immunology, where the infant has a deficiency in a component of his immune system, do not manifest themselves until 6 months after birth. By the way, anyone remember what's the name of the first milk-like substance that comes out of the mother's breast after birth? You got it, it's called colostrum. Okay. A classic step question, however, asks about a child, usually African American, being exclusively breastfed and asks what vitamin deficiency they would have. The answer would be vitamin D. Okay? Moving on to HCG. So another significant hormone is HCG, also that stands for human chorionic gonadotropin. It's synthesized by the syncytiotrophoblasts of the placenta. Now, levels of HCG increase during the first trimester of pregnancy, functioning somewhat similarly to LH, stimulating the production of progesterone by what structure? The corpus luteum. and keeping it intact and functioning. You sometimes hear this referred to as the beta-HCG rescue of the corpus luteum. HCG helps maintain the pregnancy until estriol and progesterone take over in the second and third trimester. Now, of course, as previously mentioned, elevation of HCG is also how we detect pregnancy. So what does it mean if you see severely elevated levels of HCG? This could be seen in conditions such as multiple gestations, which you can see here, as well as certain pathological states, including molar pregnancies, but we'll talk more about that in the pathology section. So another flash quiz for you. Which three hormones share structural homology with HCG? LH, FSH, and TSH have the same alpha subunit as HCG, but unique beta subunits. That's what makes them actually different. So menopause. This is the last thing we're going to talk about before we move on to male physio. So what this actually is cessation of ovarian function. Now, it's generally marked by low estrogen production and preceded by 4 or 5 years of abnormal menstrual cycles. A woman can be thrown into it immediately, however, if their estrogen production suddenly plummets, such as after bilateral oophorectomy for ovarian cancer. Now, do you remember the average age of menopause? Yeah, the onset is around age 51. But certain factors can modify this. For example, smoking. Smoking's a big one for menopause. It appears to make it happen earlier. Other conditions that can lead to early menopause include premature ovarian failure, polycystic ovarian syndrome, and endometriosis. So watch out for women with these guys. Also, any cancer of the reproductive organs will be messing up with the hormone levels, so it can also do that. Some important biochemical changes to keep in mind, however, are that FSH, LH, and GnRH will all be elevated, secondary to the loss of the estrogen negative feedback. Now, this shouldn't really be too hard to remember from an endocrinology standpoint. If the primary producing organ stops working, the whole hypothalamic pituitary axis responsible for stimulating secretion will ramp up. So in summary, what is the hormone profile in menopause? It would be increased LH and FSH, along with decreased estrogen and progesterone. Very important, however, specifically in terms of menopause, is FSH. This one will be particularly more increased than LH, and you do need to know that. That actually showed up in my exam. The signs and symptoms of menopause can be summarized by the mnemonic HAVOC, HHAVOC. So you can see them as hirsutism, that you can see over here, hot flashes, which you just see in general, atrophy of the vagina, osteoporosis, you can see that in the backaches, the loss of bone mass, and coronary artery disease. That's really the main ones that you want to remember. You would assume that management of this state is to replace the hormones either naturally with herbal supplements or synthetically with drugs. Well, you are right, but I'll leave that good stuff for farm. Okay, so we're going to round out the section by discussing male physiology, starting from the beginning with spermatogenesis. Now, spermatogenesis begins at puberty and takes about 9 weeks from start to finish. As a quick review, spermatogonia are basically the stem cells of spermatogenesis. They divide to form primary spermatocyte and also to replenish the pool of spermatogonia. So here's a primary spermatocyte. They're the first cell type committed to differentiate into mature sperm. So are they haploid or diploid? Well, they begin as 46 sister chromatids, diploid cells, with each chromosome consisting of 2 chromatids. And they undergo meiosis 1 to become secondary spermatocytes. And these will have 23 sister chromatids. Therefore, they're haploid. They still have 2 chromatids for each chromosome until they undergo meiosis 2, resulting in spermatids. And these have 23 single chromatids. They remain haploid, but now only have 1 chromatid each. This means they only have 1 copy, or 1/2 the normal amount of chromosomes in somatic cells. These spermatids will go on to become what? mature spermatozoa. What is this latter process called? Spermiogenesis. So do know that there is a difference between spermatogenesis, spermiogenesis. Spermatogenesis is the whole process that you can see right in front of you here, whereas spermiogenesis is just that last step where a spermatid turns into mature spermatozoa. Okay? So spermiogenesis is where they lose almost all of their cytoplasm and they gain what is called the acrosomal cap. Okay? So finally, we have the androgens. In addition to testosterone, there are two others that you need to know about: dihydrotestosterone and androstenedione. The latter is mainly made in the adrenals. Now, just like estrogens, these are all steroid hormones. And where are the hormone receptors for steroid hormones found? Inside the cell. In the endocrine chapter of First Aid, there's an awesome chart that goes through the whole process of steroid synthesis. For the sake of time, I'm not going to go through it again, but that is a must-know diagram. So in terms of potency for the androgen receptor, DHT is the strongest one, followed by testosterone, and finally androstenedione. So that's your potency order. So testosterone stimulates differentiation of the epididymis, the vas deferens, and the seminal vesicles, but not the prostate. Very important to know. The prostate will be stimulated by what, however? By DHT, dihydrotestosterone. Testosterone is also important in puberty, where you see a growth spurt, deepening of the voice, and eventual closing of the epiphyseal plates, ending linear growth. This is accomplished through aromatization of testosterone to estrogen. Testosterone is also very important in terms of libido. Now, do know that it takes care of libido in both males and females. Okay? A little pharmacology correlate now. Speaking of aromatization, can you name two medications that would inhibit aromatization? The answers are anastrozole and exemestane. They're used in postmenopausal women with estrogen receptor positive breast cancer. But we'll talk more about that in the pharm section. So, testosterone is converted to the more active DHT via the enzyme called 5-alpha reductase. DHT acts early in development to differentiate the penis, the scrotum, and the prostate. Later in life, it primarily acts as a prostate growth factor and also causes balding. Now, this addition right here increases the potency of the androgen receptor significantly. And what I mean by addition is that testosterone to dihydrotestosterone means that you added the hydrogen and that specific carbon. By the way, what medication inhibits the 5-alpha reductase enzyme? The answer is finasteride. Okay, so to tie in the pharm, physio, and path together, what two conditions is this finasteride drug used in? From what we just discussed, it follows that it would be used in BPH and also male pattern baldness. But once again, we'll leave that for pharm. So, now we know how the reproductive system looks like and works on a Bailey-Dacis. Next, we will see how, why, and what happens when things start going wrong. Excited? I know I am. So here's a few questions for you to work on meanwhile. Test yourself. After fertilization of the ovum, implantation occurs in the endometrium. At this time, immediately after implantation, the developing placenta begins to produce a hormone necessary for embryonic viability. Which of the following best describes this hormone's actions? Is it A, increases the threshold for uterine contraction, B, initiates parturition at the end of pregnancy, C, stimulates the corpus luteum to produce estriol and progesterone, D, stimulates the placenta to produce estriol and progesterone, E, triggers ovulation and the development of the corpus luteum? The answer is C. So the developing placenta secretes beta-HCG to stimulate/maintain the corpus luteum. Progesterone would increase the threshold for uterine contraction. Oxytocin initiation would initiate parturition at the end of pregnancy, while high estrogen would cause the LH spike to trigger ovulation. Okay, next question. 56-year-old woman is referred to a gynecologist with symptoms of dysfunctional uterine bleeding, breast tenderness, and a painless abdominal mass. after a thorough workup, an ovarian tumor is discovered and surgically resected. On gross examination, the tumor has a yellow coloration and histology reveals multiple Cowell-Exner bodies. In normal physiology, which of the following hormones acts on the cell line described to induce production of 17-beta estradiol? The answer is B, follicle-stimulating hormone, also known as FSH. Now, granulosa cell tumors are estrogen-secreting ovarian neoplasms often found in postmenopausal women. When they occur in young girls, they can produce precocious puberty secondary to the high levels of estrogen production. Within the ovary, androgens are produced in the theca cells. From there, androgens diffuse into the granulosa cells. The FSH hormone stimulates the enzyme aromatase within the granulosa cells to convert androgens to 17-beta estradiol. Elevated serum estrogen levels result in a 5 to 10% risk of concurrent endometrial carcinoma in women with granulosa cell tumors in the ovary.